Um, our speaker today is Dr. Amal Libdeh. She's an assistant professor of pediatric neurology at the University of Virginia and specializes in pediatric movement disorders. Dr. Libdeh is originally from Jordan. She moved to the US in 2011 for her pediatric residency at the University of Florida in Gainesville, Florida. She moved on to Virginia and joined UVA, where she did her pediatric neurology training and her pediatric movement disorder fellowship. She joined the faculty of UVA upon graduation in 2017 and has since established a pediatric movement disorder clinic. Her areas of interest include motor stereotypies and dystonias. Please join me in welcoming Dr. Amal Libdeh. Thank you.
Thank you so much. Thank you everyone for being here today. Thank you for your kind invitation. It's my pleasure and such an honor to be able to share this presentation with you today. Again, I apologize. I had a few technical issues this morning, so sorry for joining late, but hopefully you guys will find this talk helpful and hopefully we can get through it. So I'm just going to go ahead and start. So the talk for today will be about complex motor stereotypies. I have no disclosures and no relevant financial relationships. I'm hoping by the end of this talk, I will help you guys be able to differentiate motor stereotypies from other types of abnormal movements, discuss the morbidities associated with these stereotypies, as well as the management approach. This is the outline I'm going to follow today, going through the definition, differential diagnosis, as well as management. And before I start the definition or tell you what the definition is, I always like to start with this slide, which is kind of what we usually do in the pediatric movement disorders clinic whenever we see someone who's presenting for evaluation of abnormal movements. So these are the types of questions that we typically would ask about to try and characterize the movement of concern. We start by deciding whether the movement is hyperkinetic or hypokinetic, whether it's paroxysmal or whether it's happening continuously, whether the movement itself is rapid or slow, and if it's episodic, then whether the episodes are brief or prolonged. We ask about the time course, whether these movements are new or have been there, whether they started suddenly or insidiously, and how they changed over time. And then we ask more specific questions regarding the ability to suppress or control the movements, the factors that make them better or worse, whether they're causing any functional impairment. And importantly, we always ask if the movements are present during sleep. And these are the questions that help us differentiate different types of abnormal movements. So keeping these questions in mind, the definition of motor stereotypies would be that they are involuntary, repetitive, fixed and rhythmic movements. So they are a type of hyperkinetic movement disorders. They are predictable in pattern and they seem purposeful, yet they are purposeless. So the type of movement itself may appear normal, but it happens out of context and it really serves no purpose. During the event, the child may cease all other activities, but they don't really have any altered level of awareness. These movements are not preceded by an urge or any thoughts, and that differentiates them from other types of abnormal movements. They can be temporarily suppressible and are distractible, and they are not present during sleep. The episodes during which these movements happen could last seconds to minutes, and they may appear multiple times a day. And there are few triggers for these movements, including excitement, stress, fatigue, boredom, or being engrossed in activities. I always tell parents that they can be triggered both by positive type of stimulation as well as negative type of stimulation when the child isn't doing anything. And to talk about the classification or the types of movement disorders, I feel like this way of looking at them may be helpful. So one way to divide them would be to say that there are primary or physiological motor stereotypies, and then there are the secondary ones. Generally speaking, the primary ones are the ones that happen in typically developing children, and the secondary ones are the ones that happen in children with developmental disorders. There are subcategories for the primary physiological motor stereotypies, and these include the common ones. They're called common because they're common, so things like body rocking, earth whirling, and so on. The other subcategory is head nodding, and that one happens in different directions. Sometimes it can be sideways, yes, yes, or no, no, or even a figure of 8 type of head shaking. And then there are the complex motor stereotypies that include a combination of handshaking, flapping, and so on. On the other hand, the secondary ones may have similar types of movements, but again, they happen in kids with developmental disorders, and these include kids with developmental delay, intellectual disabilities. We frequently see them in kids with sensory deprivation, such as blindness and deafness, kids with neurodevelopmental conditions, obviously autism and Rett syndrome, kids with certain neurogenetic and neurometabolic conditions, as well as people that have been exposed to traumatic brain injuries, sometimes medications, infections, and tumors. So I'm going to show you a few videos that give examples of the various subcategories of motor stereotypies that I mentioned. So this is a child who is presenting for this evaluation of this movement. So it would be an example of the head nodding. This is actually a common reason for why I would see a patient in clinic, because many times people would worry that the child may be having seizures when they actually aren't. So this is one kind. This is another type, again, a commonly seen motor stereotypy, the hand flapping, commonly associated with autism. This video shows two, maybe three patients with a similar condition. I'm going to let you look at it for a few seconds, see if you guys are able to recognize it. It's a stereotyped characteristic type of motor movement in girls with this condition, with the hand wringing, repetitive movement. So all these girls have Rett syndrome, and that's an example of secondary stereotypies. And this is actually one of my patients. He developed these movements following an acute brain injury. This child had a case of adrenal insufficiency and presented to the ICU with an acute episode of hypoglycemia that led to brain edema. He actually had brain herniation but survived that, but ended up with this movement. So that again would be an example of a secondary motor stereotypy that happened in the setting of brain injury. And as far as the prevalence of motor stereotypies, it really varies between the different categories. So I mentioned the common ones are generally common, even in typically developing children, with prevalence reported between 20 to 70%, depending on the study you look at. The complex motor stereotypies are less common, but still happen in 2 to 4% of the typically developing children. It's 66% in kids with developmental delay and intellectual disabilities, and it also is noticed in up to 88% of patients with autism. And for the purposes of the remainder of this talk, I will actually be focusing on the primary complex motor stereotypies, and that's where the rest of the points in the outline will be focusing on. I'm going to show you another video to give you an example of what a typical complex motor stereotypy would be. And this is what we usually see in clinic. So if you look at this child, you see that he kind of has multiple types of abnormal movements happening repeatedly. So there is the arm movement, sometimes up and down and sometimes sideways. It started when he was pacing in circles, so that's another type of repetitive movement. And then if you keep watching and see what happens when the child is playing, you'll see that initially the child will stop playing while engaged in the movement. But then when the movements stop, he's able to resume playing. And like I said, this is a common example of what primary complex motor stereotypies are. And these movements typically involve the upper extremities with like various types of movements, including twisting, flapping, shaking, and so on. It also includes jumping, pacing, mouth opening. Sometimes there can be vocalizations. And the child may have more than one type of motor stereotypy, like you saw in the video that I showed you. And these movements typically tend to be consistent and fixed over time, but you could possibly see some evolution in the nature or the phenomenology of the movement. They are generally noted before the age of 3 years, and that helps us differentiate them from other movements that tend to have later occurrence, such as tic disorders. They should be present at least for 4 weeks when you're making the diagnosis, because this is considered a chronic condition. They're more prevalent in boys compared to girls, with a ratio of 3 to 2. And up to 40% of children would have a positive family history of stereotypy. I wanted to focus the next few minutes on what else may be considered in the differential diagnosis when we see these movements. So usually there's a concern that these may represent seizures. And generally speaking, it's easy to differentiate them, especially in people that have the generalized bilateral type of abnormal movements, because as you might imagine, because these movements are suppressible, they are distractible, the child has an intact level of awareness, they can easily be differentiated from seizures. That being said, sometimes the movements start on one side of the body, and sometimes the child will be so engaged in doing them that you may question the diagnosis. So there are times where I had to get an EEG to make sure that we're not missing seizures, but generally speaking, the differentiation should be easy. The other thing to think about when faced with these movements would be tic disorders, and that's a common question and something we have to think about every time we see a child presenting with motor stereotypies. So this is a video of a child with the most typical tics. They mostly have the movements in their face. They tend to be more rapid, more brief, and even though they tend to be repetitive and of the same nature, they don't happen in the same order like we see with motor stereotypies. That being said, this is another example of tic disorders, and you see that this patient does have upper and lower extremity movements, similar to what I just mentioned about motor stereotypies. And that's when it sometimes gets tricky, and it becomes more important to gather more information from history to make sure we're not mixing it with tics. And these some of the things that I find helpful to differentiate motor stereotypies from tics. So first of all, the age of onset stereotypies tend to start at a younger age. The movements do tend to involve arms and legs more than face, and that's the opposite in tics. The really important part of differentiating is the presence of an urge, which is that feeling, that sensation that people would report prior to the onset of the movements. Not everyone with tics will have that urge, but if it's present, then you know that you're dealing with tics, and patients with primary motor stereotypies will not have that urge. The triggers tend to be similar, but generally speaking, the motor stereotypies tend to happen more when the child is engrossed in a certain activity, while these actually are, the tics are distracted when the child is engrossed in a certain activity. And then really, the thing I rely most when I'm talking to a child in trying to differentiate motor stereotypies from tics is how they feel about it. In my experience, I feel like motor stereotypies tend to be enjoyable and soothing to children when they have them, while tics tend to be annoying and associated with a lot of discomfort and stress. So the typical history that I get from people is that usually it's the parents that bring the children to me for motor stereotypies. The children themselves aren't really aware that they're doing the movements, and they don't really care. And it doesn't matter to them if someone were to ask them to stop doing these movements. On the other hand, the tics are usually most annoying to the patient, and they come because they are so uncomfortable and annoyed by these movements. And if someone were to ask them to stop these movements, they find it more stressful and may lead to worsening of the movements. So these are usually the things that I try to figure out from the history to try and differentiate these. And generally speaking, we're able to differentiate, but sometimes it can be difficult. The other thing to keep in the differential diagnosis is OCD, because people could have repetitive movements in the setting of OCD. And people with OCD will report thoughts and feelings preceding the movements, and that again is not present in complex motor stereotypies. The topic of tics versus OCD versus stereotypy has been the subject of multiple research projects, as you might imagine. Generally speaking, when we describe it, we kind of tell people that people that have these movements aren't able to inhibit them somehow. So we always are talking about inhibition and how that is impaired in these types of abnormal movements. This is a group of researchers that published multiple articles after testing different kids with tics, with motor stereotypies, and with OCD using a simple experiment of the go, no go type. And they tried to figure out if there is really an actual impairment of inhibition in patients with these conditions. And they did find a difference depending on the condition that they were testing. So when tested objectively, they realized that people with tics don't really have any impairment in their inhibition. Both the reactive and the proactive were intact in patients with tics. They both were impaired in patients with OCD. But in patients with complex motor stereotypies, they realized that the reactive inhibition is normal, while the proactive inhibition is abnormal, meaning that the patients, if they are asked to react immediately, they may not be able to do that, but if they know what to expect, that they may be able to react better. And I feel that helps us understand some of the symptoms that are associated with motor stereotypies, and also helps us when we're trying to figure out how to better manage these and treat them. And the last thing I wanted to mention in the differential diagnosis from motor stereotypies is actual hyperkinetic movement disorders, including chorea, dystonia, and myoclonus, because some of the components of movements of motor stereotypies may look like these, so it's important to differentiate them from the primary movement disorder conditions. So I wanted to show you this video. This is an example of an actual case of genetic dystonia, where the patient has it on her left side. You see that she's able to write just fine with her right hand, but as soon as she holds the pen with her left hand, you see how it assumes a dystonic posture and her handwriting is abnormal. More importantly, during the exam, you see that the hand is assuming a dystonic posture even when the child is not engaged in a motor activity, and that persists during different positions. So you see that it's present with action, but also her exam is also abnormal and shows the dystonia. On the other hand, I wanted to show you this example. So this is a child that I saw in clinic who presented for something similar. Every time she writes, her hands assume this dystonic posture and her handwriting is abnormal. But if you look at what she just did, even though her left hand was in this dystonic posture, as soon as she tried to type or press on her iPad, the dystonia resolved and she was able to do that. I'm going to show you the same child in a different setting. So here she's just playing, she's talking. You can see the intermittent dystonic posturing with her arm, but she's also able to interrupt that when being distracted or when she wants to hold something, and she's able to resolve it. And then this is the same child in clinic while we were examining her without being engaged in that abnormal movement, and really her exam is normal. She doesn't have any dystonic posture. So the things that help differentiate from the primary dystonia disorders in this case versus motor stereotypies is our ability to distract the child from doing these movements and the fact that their neurological exam should be normal. This is actually another example of another child with motor stereotypies, again presenting with something similar, where at the first glance you would think that she has dystonia, but really she's able to interrupt these when she's engaged in the playing. And that again is what helps us differentiate. Now, what's the etiology of complex motor stereotypies? We don't know. There are a couple theories, but the exact reason is not really known. We think maybe there's a Mendelian inheritance, and that's just from the fact that maybe close to half of the patients will have a positive family history. So we assume maybe there is something to that effect, but there are no specific genes that have been identified yet. And many people are talking about the possible contribution from certain environmental factors that lead to over or under stimulation, such as things related to prenatal stress. But again, there has been nothing proven yet. People generally talk about psychogenic versus neurobiological etiology. So some people think it's psychogenic in origin. It's a form of self-stimulation, a substitutive behavior for imaginative activities, or related to poor sensory motor integration, poor impulse control, or maybe some sort of an obsessive compulsive or general anxiety disorder. On the other hand, many people believe that's actually neurobiological in origin. Why? For once, because you can actually induce stereotypies using certain medications in animal models. Also because stereotypies can be seen as side effects from certain medications that have dopaminergic effect. Also because it can be associated with CNS disorders such as autism and intellectual disabilities. And because it can be seen after brain insults, including stroke and traumatic brain injury, similar to the child I showed you at the beginning of the presentation. And for the pathophysiology of primary complex motor stereotypies, I just wanted to start with the simple explanation leading to what the researchers are looking into. So at the most basic level, we know that the signal for the voluntary movements originates from the primary motor cortex to the pyramidal tract to the spinal cord and to the muscles. But then there are the more complex motor activities that involve a series of parallel circuits that involve the frontal cortex, basal ganglia, thalamus, and cerebellum. They have this long name of corticostriatal thalamocortical circuits. I wanted to include this. I'm not going into details with it. I just wanted to remind everyone of the position of the different basal ganglia, the caudate, putamen, globus pallidus, and then you may be familiar with the direct and indirect pathway and the circuits involved within the basal ganglia, but just wanted to point out that there are so many neurotransmitters that are involved in these pathways, not just the dopamine, but also the glutamate, the GABA, and so on. So with these circuits in humans, we have three main ones. We have the goal-directed circuit that involves the prefrontal cortex and the caudate. We have the habitual behavior circuit that involves the premotor cortex and the putamen. And we have the emotion-related limbic circuit that projects input from the hippocampus, amygdala, prefrontal cortex, and anterior cingulate gyrus to the ventral striatum. And as you might imagine, these are the structures that the researchers focused on in trying to decide what may be contributing to the pathophysiology of complex motor stereotypies. So I'm going to go over a couple studies that talked about this topic. This study was from 2005. It looked at the structures of the brain using volumetric MRI and compared patients, 6 patients, all of them were males, and all of them had complex motor stereotypies, and they had a control group of healthy patients. And this study showed that there were reductions in the frontal white matter and the caudate nuclei, and they concluded that this suggests some dysfunction of the circuits that we just mentioned. There was another study from 2016. This one just used anatomical MRI. They had more patients, 12 patients, some of them boys, and there were 8 girls, and they also had age-matched controls. And using the anatomic MRI, this study showed reduction in the putamen. And that, again, pointed to the fact that these circuits are involved, and maybe specifically the habitual pathway. And this study actually looked at the neurotransmitters. So it was from 2016. It examined 18 children with complex motor stereotypies. It used MR spectroscopy, and they showed that there is a lower level of GABA in the anterior cingulate cortex and the striatum. And when they looked at the other neurotransmitters, they did not see any difference between the patients with motor stereotypies and the controls. So they concluded that maybe there's a role for the GABA dysfunction in this condition, and again, pointing to the involvement of the circuits. So why do we worry about complex motor stereotypies? They do seem like they're benign. We know that the movements themselves do not lead to brain damage, and that's something I always point out to patients. So why do we worry about them, and what do we see in effect in patients that have complex motor stereotypies? Actually, most children that have this condition will have intact neurocognitive profile, and they perform at or above average in their academic settings. And children frequently deny any concerns for physical issues. Like I said, many of them would tell me that they're just here because their parents brought them, and they don't even know what their parents are talking about. But unfortunately, many kids with motor stereotypies will deal with issues of low self-esteem, social stigmatization. Sometimes teachers would report classroom disruption, or that the movements are interfering with their academic activities. Parents would report issues with attention and executive difficulties, more likely in kids with complex motor stereotypies. And unfortunately, many kids with complex motor stereotypies will have comorbidities. When looking at different studies that examined patients with complex motor stereotypies, we can tell that more than 90% of them would have at least one comorbidity, and more than 65% would have 2 comorbidities. These are the lists of the most common comorbidities associated with complex motor stereotypies. These may look familiar because they're similar to the ones seen with tic disorders. So ADHD and OCD are commonly seen in patients with motor stereotypies, as well as in patients with tics. Tics and stereotypies could coexist, and really there's a high prevalence of coordination disorder and executive dysfunction. And you can see that the percentages reported are variable, and really the higher numbers tend to be reported more in cohorts that had older patients. And how we manage complex motor stereotypies. So unfortunately, it's not that easy. There are so many medications that people have tried to try and help with motor stereotypies, but none of these has been helpful. We don't have any evidence that a specific medication is successful in suppressing these movements. We wanted to include all the medications that people have tried for the management of motor stereotypies. These included ADHD medications, SSRIs. People have tried antipsychotics, DOPA medications, because it makes sense since it has been involved in the pathophysiology, many anti-seizure medications, as well as other medications. None of these has been helpful, and we try to stay away from using them. One thing I wanted to mention, though, is that there are a couple medications that have been used in the treatment of secondary motor stereotypies. So you'll see a lot of articles describing the use of SSRIs in patients with autism. We also frequently use Risperdal in patients with secondary motor stereotypies that are associated with self-injurious behavior. So there is a room for the use of these medications, but just not in the primary complex motor stereotypies. So what do we do instead? Really, the only way that we have so far for the management of complex motor stereotypy consists of cognitive therapy. So we have the habit reversal therapy that I'm sure you guys are familiar with because we use it for various types of abnormal movements and repetitive behaviors. And it made sense to use it for complex motor stereotypies. And for people that aren't aware of the principles of habit reversal, what it does is that it has two components. The first one is what we call awareness training. And in that part, we basically teach the patient to become more aware of the movements that they are doing. We ask them to describe the movements, we ask them to imitate the movements, we ask them to reenact the movements over and over again and talk about the components of it and all that until they're fully aware of what's happening. And then the second part that is involved in the cognitive therapy for habit reversal therapy is what we call competing response training. And with that, what we do is we teach the patient to do something instead of the movement of concern, something they choose, something they have control over, and then we teach them to do it every time the movement happens or they have the urge to do the movement, hoping that it will replace it and it will help lower the frequency of the abnormal movements. So for complex motor stereotypy, this is what we do. We start by having the child be more aware of the movements, and then we start with the competing response and helping them suppress these movements. And the first study on this topic came out in 2006. They basically examined 12 children using this type of therapy. This one was provided with psychologists and therapists, and they reported a drop in the severity score for motor stereotypies. But the issue that we have is that we have a limited number of therapists, and we don't always have the availability to refer patients to therapists that are able to provide the cognitive therapy. So this study from 2017 by the same group showed whether we can do that with the help from the parents. So what they did was that they put the principles of the cognitive therapy that they wanted to do for patients with complex motor stereotypies on a DVD. They had like a handout for patients. They had an actual video that shows the kids what they're supposed to do. And they basically followed up these patients to see what happens with them. And they had a good number of patients. They actually started with 81 patients with complex motor stereotypies, but unfortunately, many of them did not complete the study. So they had a 64% drop out. They did show a reduction in the severity of motor stereotypies, but again, it was a small number that they were left with at the end. So this study in 2018 actually used both. So what they did is that they relied on the parents, but they asked the therapists to follow up with them during using phone encounters. And they again showed an improvement in the severity scale of stereotypies. And the good thing is that the dropout rate was less. So it was 36% compared to the 64% of the study that relied on the parents only. So the use of cognitive therapy in the management of complex motor stereotypies appears to be beneficial. It is effective. This is the summary of the 3 studies that I just talked about, the one that used the therapist, the one that used the home videos, and the one that used both. And like I said, they all showed reduction in the severity of motor stereotypies. Maybe the most effective was the one that used the video and the therapist. And then again, the issue with the dropout, that was most in the ones that relied solely on the parents, and it was less when the therapist followed with the parents through phone encounters. And the other thing I wanted to talk to you guys about is the prognosis of complex motor stereotypies. So what happens with the patients? Do they continue to have these movements? Do these go away? So I think the initial thought was that the movements would usually start during infancy. They will continue to increase maybe through the 3rd, maybe 4th year of life, and then it will start declining and maybe resolve. I think that was the initial thought that many people had in mind. But we unfortunately realized that that's not true. What happens really is that over time, older children and adults, they learn to suppress these movements, they learn to mask them and include them in other more purposeful movements to try and hide them, but they don't really go away. So we have few studies that examined this topic. There is this study from 2004, and they reported on 40 children with complex motor stereotypies, and the mean age at the time of the study was up to 17 years. They noticed that the movements would only resolve in 5% of the patients after a follow-up of up to 10 years of duration. For most patients, the movements either remained unchanged or improved, but like I said, the chance of them resolving was very small. There was another study from 2008, again, a much bigger number of patients, 100 patients of primary complex motor stereotypies were followed, and they were contacted to see if their movements had resolved. But again, the chance of these resolving was very small. Of the 100 patients, only 6 of them reported that their movements had stopped. And actually, of the 6 patients, 3 of them had the head nodding motor stereotypy, which is technically more likely to resolve compared to the primary complex motor stereotypy. So basically 3 out of 97 patients with complex motor stereotypies continued to have the movements at the time of this study. And this is the third study from 2015. It actually is the longest, so they checked with patients up to 20 years after the onset of their complex motor stereotypies. And for these patients, they suggested that the rate of resolution was 2%. So like I said, the general thought was that these may be movements that would resolve over time, but it turned out not to be true. And this is something I make sure to tell my patients every time I counsel them on this condition, because it helps them to know what to expect. So even though many other types of abnormal movements may resolve, especially the ones that start at a young age, but this type of movement, I always explain to them that it will likely stay. It could fluctuate. So there are times where the family would feel that it may be resolving or that the child may have gone for a couple months without having them. But in my experience, they frequently would come back and have them again. So even if the parents would report to me that the movements are gone, I usually make a point of telling them that it may come back and that they shouldn't be surprised if these movements were to happen again, that they don't necessarily indicate something unusual, because that is what we would expect from the natural history of the movements. Not only that, but I do tell them extensively about the triggers and what might exacerbate these symptoms, because these movements are considered soothing for patients. A lot of times we see the exacerbation of movements if something else is going on that may trigger them. So especially in patients that have limited vocabulary and are unable to express themselves, a lot of times they'll have physical issues that would project in the form of worsening of their stereotypies. So whenever someone is coming to me with acute worsening of their motor stereotypies, rather than focusing on treating the stereotypies and how we can mask the movements, one of the things I try to do in clinic is to try and figure out why that happened. Sometimes we are able to reveal some stressful events that are happening in the house, and then we're able to counsel the families about the role of these stressful events in the worsening of stereotypies. And I've also seen patients that have the exacerbations due to physical conditions, and that is more important in patients that have significant developmental disabilities, the ones that really can't express their feelings and what may be bothering them. So I've seen patients with exacerbations of complex motor stereotypies simply because of gastroesophageal reflux, or in the setting of a urinary tract infection, or I saw a patient who had a femur fracture that was missed and her family brought her because she had worsening of complex motor stereotypies. So I always explain to parents that this is one way the child expressed themselves, that we should focus less on the frequency of the movements and more on why they're happening more and how we can help the child calm down. So this is what I wanted you guys to know about motor stereotypies. This is the quick summary. So stereotypies are ubiquitous. They occur in a variety of forms and exist in different patient populations. Primary complex motor stereotypies appear to have a neurobiological cause, with preliminary data showing reductions in the volume of putamen on MRI and diminished levels of GABA in the anterior cingulate and striatum on magnetic resonance spectroscopy. Stereotypies can be associated with social stigma, they can cause distraction, and they are commonly associated with comorbidities. Making the accurate diagnosis is important to provide proper counseling and to screen for comorbidities. And pharmacotherapy is largely not beneficial. Cognitive behavioral therapy seems promising, and there may be an option to do it at home. These are some of the references I used to prepare this talk, and I'm happy to take any questions.
It should be letting me share now. Let's see. All right, so our first question on motor stereotypes is, are they voluntary, repetitive, fixed, and rhythmic? Are they not predictable in pattern? Do they show altered awareness? Are they preceded by an urge or thoughts? Are the movements temporarily suppressible and distractible, or are they present during sleep? So if everybody can answer in the chat, give them a few minutes there. Looks like people are getting the answer. And the answer should be E. Movements are temporary, suppressible, and distractible. And we'll go to the next question. That lets me. Okay, so CMS, is it typically involving the lower extremities, includes jumping, pacing, mouth opening, head posturing, and vocalization, or do the movements not evolve? If everybody wants to answer in the chat. Okay. All right. We got it. It is B. All right. Stop sharing and go back. All righty. So if anybody has questions, make sure and put them in the.
Yeah, so there is a question. I see, how young can we start habit reversal therapy? That's a good question. Generally speaking, we always say you can start it at a young age. We just have to think of the nature of the exercises that are done during the habit reversal therapy, because like I said, the child will have to be able to express what type of movements they're having and be able to imitate them and then participate in the activity of trying to suppress them for an increasing amounts of time. In my experience, usually they'll have to be school-aged kids to be able to participate in that. I would rarely refer children that are younger. So like I said, they do start at a much younger age. I mean, you could see it in a 1-year-old or a 6-month-old, but I usually tell parents to wait until the child is at the school entry age before we refer them to this type of therapy.